lot of times too from patients as far as how would you diagnose any type of lymphoma?
So really the physical exam is probably the most important and maybe the most reliable way to make a diagnosis of lymphoma. So when you're seeing your physician, they'll examine you, they'll look for enlarged lymph nodes in the neck, under the arms, in the groin. They may look for enlargement of the liver or enlargement of the spleen. Those are the things that the physician would look for. In the laboratory, when they do blood tests, there may be anemia, meaning a low red blood count. The white blood count may actually be elevated, but it may also be lower than normal. And the platelet count, which is a part of the blood which helps to stop bleeding, may be either elevated or more commonly may be below normal. Once the diagnosis is suspected, then I think most physicians would order some imaging tests, and the imaging tests are, for the most part, CAT scans, which show an anatomic picture of the lymph node areas throughout the body. So a CAT scan is often part of that diagnosis. And then if an abnormal lymph node is seen either in the neck or under the arm, or it's seen on a CAT scan, the next step would be to do a biopsy. And it's important, I think, to remind people that in order to make a diagnosis of lymphoma, either non-Hodgkin's lymphoma or Hodgkin's lymphoma, you need enough tissue to make a diagnosis. And I'll put my first warning out here that the fine needle biopsy that's often done is usually not adequate for a diagnosis of lymphoma. So I think that if there's an enlarged lymph node present, I would say, and lymphoma is suspected, then a fine needle aspirate, which is often the easiest thing and often the first thing that's done, I would say should probably be put on the back burner, and an excisional biopsy where a surgeon actually takes a small piece of the lymph node or removes the entire lymph node should be done.
And I think you're saying that because as far as what I have, learned from my experiences, because when you do the aspiration, is it possible you could miss some of the cells in it?
Right. So we know that lymphoma can be spotty in a lymph node. And if you put the needle in one spot, you may find it. If you put the needle in another spot and you can't tell where you're putting the needle, then you may miss it totally. And so we often will get sort of the non-diagnostic needle biopsy, then the regular biopsy has to be done afterwards.
Okay. And what are the traditional treatments that you would go with? I know there's radiation, chemotherapy, and a combination. Are those basically the traditional treatments that you go with?
So yes, radiation is still an important part of the treatment of many types of lymphomas. For many years, it was the only treatment that we had. And over the years, in the 70s and 80s, it was clear that chemotherapy was effective in lymphoma, and the concept of combining chemotherapy drugs one with another showed that we could improve the results dramatically. And so eventually chemotherapy became part of the mainstay of the treatment for both non-Hodgkin's lymphoma and for Hodgkin's disease. And then in the late 80s and early 90s, basic laboratory research, the kind of research that this foundation is trying to fund, revealed that most patients, maybe 90% of patients with non-Hodgkin's lymphoma, mostly the B-cell lymphomas, have a protein on the surface of their cell called CD20. And that protein then becomes a target for new treatments. And that development of that protein, the recognition of that protein, led to the development of an antibody. That antibody was eventually named rituximab or Rituxan. And that, starting in the mid-90s, we started research in that in the early 90s. The drug was approved in 1996 or 97 for the treatment of non-Hodgkin's lymphoma, mostly for the indolent or low-grade lymphomas. And then people started recognizing that if you combine that Rituxan with chemotherapy, the response rates dramatically improved. And so I would say today, for patients with B-cell non-Hodgkin's lymphoma, either aggressive or indolent, that Rituxan is part of the initial treatment. And actually, there are good data now that it may be part of what's called a maintenance treatment for some patients with non-Hodgkin's lymphoma. So now I would say the mainstay of treatment for most patients with lymphoma, non-Hodgkin's type, is Rituxan plus some chemotherapy.
So you're basically using it as the traditional treatment, the Rituxan now, because at first it was kind of, doctors were kind of leery to use it too much because of the suppressing the immune system.
Right. So it does suppress normal B cell function, and there is a certain, one of its risks may be the development of infections. From what we're seeing, though, the risk of infection is really no higher than it is maybe with chemotherapy. And if you use Rituxan alone, which in many lymphomas you can do, that risk really isn't above what you'd expect to see. If it's given endlessly and continually, then the risk starts to go up, we think. So, but I think it's an important part of the treatment of any of the B-cell non-Hodgkin's lymphomas.
Well, it almost seems kind of like a little miracle drug that's been put out there. Would you kind of call it that, or?
Well, I think it's
one of them.
It's one of them. I think it's an important milestone in the treatment of lymphoma. And what I would stress is that it didn't just happen. Wasn't an accident. It happened with a lot of very important, carefully done, basic research that took a long time to do, took lots of funds to do, and took some smart people to figure out. And I think it's that kind of advance that we're looking for. Again, we're looking for the new Rituxan, we're looking for a better Rituxan, we're looking for a better understanding of how lymphomas grow and how we can make them die. That's really
and that's why we need research, and to give research dollars in hands like yours, so we can find new treatments and a cure down the road. So, as far as like with the new treatments that you have, the traditional new treatments like Rituxan, what's the prognosis and survival rates that you're seeing now with the better treatments? Let's put it that way.
So first of all, without being specific about any one type, what we've seen first in the aggressive lymphomas, where the initial chemotherapy could be curative in a significant proportion of patients. Whereas before, if you took the worst case scenario, somebody with a very aggressive lymphoma, maybe only 15 or 20% of patients were still functioning normally without disease 10 years later. Now I think we're seeing 50 or 60% of patients in the worst case scenario. In the best case scenario, it's 90 to 95% of patients may be cured of their disease with very early diagnosis and a disease that has certain characteristics, without disease presenting without a lot of symptoms. So we've improved the worst case scenario from 10 or 15% to greater than 50%. So I think that that's a major improvement. And in the low-grade lymphomas, we're now seeing prolonged survival without disease, such that it's hard to even measure the median since the introduction of Rituxan. We don't know what the median survival is because we haven't reached it yet, many years after the development. So we do think that the use of these new antibodies like Rituxan has led to striking improvements in the cure rate, both for the low grade and for the high grade lymphomas.
And as far as, again, I'm going to go back to the research development and the impact that research, if you could just briefly say again how important research is to impacting newer treatments.
So I think there's two forms of research that are equally important. You need the basic observations in the laboratory from basic scientists to recognize what causes these cells to grow, what causes these cells to die, and to recognize these proteins that you're trying to target. And then you need clinical research that is done primarily by clinicians, by people who are working with patients, to translate those basic observations from the laboratory into the patients. And the reason that's so important is sometimes the basic scientists are sort of following the lead of the basic science, but not necessarily thinking about how it's going to apply to patients. And it takes that collaborative effort between basic scientists and clinicians, which is what's being done at most academic medical centers now, to really translate it into some meaningful improvement in survival for patients.
Okay. Time's running out on us here, so I'm going to ask you briefly if you can just maybe give some information to patients who have lymphoma, or where they can contact you, and how patients can contact you.
Well, I think that there are publications that come out through the National Cancer Institute, through a variety of other research foundations in lymphoma, Lymphoma Research Foundation, National Cancer Institute, where people can get information about lymphoma. People can go to any research institution, or really any hospital, but certainly any research institution where there's a specific interest in lymphoma, and go to either the Northwestern website, the Rush website, a variety of other places, or the Chicago Blood Cancer, of course, Foundation
yes.
website, to try and get information about new treatments and new clinical trials, and also how to talk to some of the people that are doing research in this area. It's not necessary to actually doesn't necessarily see somebody in an academic center if you've already gotten a couple of opinions, as Scott has mentioned. But I think most of us would be very happy to talk over the phone with patients and with their doctors about new treatments that might be available.
Well, and I know just on a personal basis, Dr. Gordon, you are just really tremendous with your patients, and the things you have done for them is just remarkable. And I know a lot of them, so. And they're living well today and surviving. So I want to thank again Dr. Leo Gordon from Robert H. Lurie, Northwestern University Medical Center. And I want to thank you so much for being our guest today.
You're welcome. It was a pleasure to be here.
Thank you.
Okay.
We're going to just take one moment, and then I wanted to just give you our website again. It's Chicago Blood Cancer Foundation, and it's www.chicagobloodcancer.org. And our telephone number is 888-792-9992. And now we're going to bring Scott here, and he can talk a little to you.
And so, ladies and gentlemen, you've learned as much as you can possibly learn in 25 minutes about lymphoma from one of the best in the business. Join us next week for Battling and Beating Cancer, and our guest is going to be Dr. Howard Kaufman, the Cancer Program Director at Rush University Medical Center. And our topic, which is a great follow-up from today, is cancer research is the key to our long-term survival. We'll see you next time here on Battling and Beating Cancer.